Okay, welcome to the Grand Round Series EASL 2017. My name is Pietro Lampertico, Professor of Gastroenterology. I'm the head of the Division of Gastroenterology and Pathology at the University of Milano, Policlinico Hospital. Our unit has been involved for many years in the liver disease management. For many years, the liver unit has been managed by Professor Massimo Colombo. Many doctors in the liver units have been involved in several international studies, multi-center studies, and also in the writing of the guidelines, viral hepatitis B, viral hepatitis C, liver cancer, portal hypertension guidelines. This is a large unit. We are managing several thousand of patients on an liver clinic basis, and many other patients in the inpatient liver unit. Today we are here for a case on clinical viral hepatitis, and with me there are two very well-known doctors, expert in liver disease and specifically in viral hepatitis from our unit. Dr. Alessio Aghemo on my left-hand side. He's been involved also not only in international research on viral hepatitis C, but also he's been serving for some time in the government board on EASL and has been actively involved in the management and writing guidelines, EPSI, even the last one in 2016. On my right-hand side, there is Dr. Roberta D'Ambrosio, again, another doctor from our unit. Again, very experienced on viral hepatitis, mainly on hepatitis C, and also she spent some time in the Pierre Bedosal lab in Paris working on liver histology. So now I'd like to give word to Dr. D'Ambrosio. She will start the case on the management of viral hepatitis.
Good morning. The patient I will present is a 31-year-old man who was referred to our center for HBV/HCV co-infection. In his history, he had some risk factors for sexual transmission of infection, as well as a father on regular clinical follow-up for HCV-related liver cancer. In 2002, blood examination showed slight moderated increased transaminase values. It tested HCV RNA positive, genotype 1b. It tested also S antigen positive, E antigen negative, with a low HBV viral load. The status was consistent with an active carrier. Also, serology anti-HDV was negative.
So, Alessio, apparently this is a case of co-infection, Hep C and B. And I have actually three questions for you. The first question is, how frequent is this co-infection? The second question is, what is the interplay, virologic interplay between these two viruses, as long as we know today? And the third question is really probably the most important. So, which is the long-term outcome of Hep C, HBV co-infected patients compared to either HCV mono-infected patients or HBV mono-infected patients?
Yeah, well, Pietro, you know, the quality of the data in terms of epidemiology of HBV/HCV co-infection is not so good. There's probably an underreporting of cases. But if you look at the overall picture, you see that around 10 to 15% of the patients with chronic hepatitis B are currently co-infected with hepatitis C. The data from Europe is probably slightly lower. You're going to be around 5%, 10% maximum. Of course, if you move to the Far East, where the prevalence of hepatitis B is much higher, the number increases. But really, there's a slight gap in the data. If you look at the quality of the published literature, we still don't know how many patients we are currently facing with chronic hepatitis B and C co-infection. And this is relevant because as you said, there's a sort of interference between the two viruses, as usually you see three possible patterns. You have some patients, and this is the majority of the patients we see, for example, in Italy, where HCV will dominate HBV, and you will have, as you can see, basically over here, down here, HCV RNA positive, high level, HBV DNA with a pattern of an inactive carrier, so low-level HBV DNA, and probably no significant liver damage, although it's hard to understand if the damage in the liver you find is HCV or HBV related. However, this condition is not really stable, so you have some patients who fluctuate and might become active for HBV replication. And this is why, if you look at the papers, the general recommendation is to monitor both HCV and HBV replication at least once a year, because this pattern can change during time, and you have patients that will go in and out of the inactive HBV carrier phase, and they will develop eventually also an HBV disease. But what is most relevant is that if you compare these patients to the ones that are monoinfected with HCV or the ones that are also monoinfected with HBV, the co-infected patients have a worse prognosis. They have a faster disease progression to cirrhosis. And if you look at the data coming mostly from Asia, where you have the biggest cohorts, there's also a higher risk of liver cancer in these patients, which actually in terms of a hazard ratio is very, very high, more than 100 times higher risk of developing liver cancer compared to patients that do not have chronic infection with both viruses. So this is a group of patients that in the old times we would have defined as a high priority for treatment, because the risk of developing complications is really high in these patients.
So if you agree, I would say the first take-home message of this clinical case so far, and this will be also relevant at the end of our presentation, is that everyone with HCV infection must be tested for HPV markers. This is very important for not only treatment indications, but also for the long-term outcome. So please, Roberta, could you go back to the case? What is going on with this case after 2002?
In 2002, an ultrasound led us to exclude portal hypertension signs. However, as we usually did in that period, we offered the patient a liver biopsy to assess the fibrosis stage, which was a mild fibrosis S2 according to the IJEC scoring system. We offered also antiviral treatment with big interferon ribavirin. The patient was young, without comorbidities. He had an increased risk of faster fibrosis progression over time because of his co-infection, and had a family history positive for liver cancer. Unfortunately, treatment was stopped at week 16 of treatment because of the onset of bone marrow aplasia. At that time, the patient did not take any drug for his HBV infection. Therefore, we followed up him over time with a non-invasive measurement of stiffness. And in 2009, we performed a second liver biopsy, which showed a slight increase in fibrosis stage, which was at that time S3 according to the IJEC staging system. From March 2009 until July 2015, the patient remained on stable and regular follow-up. As you can see here in blue, transaminases value remains stable, fluctuating, and HBV DNA levels remained very low. Probably this activity was the result of the dominant replication of HCV RNA over HBV. In August 2015, these were the blood examination, stable transaminases values, liver function tests were preserved, and a platelet count which was normal. However, transient elastography showed an increase in liver stiffness, which at the time was consistent with advanced fibrosis, and an ultrasound led us to exclude again the presence of cirrhosis.
So if I can make a comment right now, and maybe a question, the comment is really according to this virological profile for hepatitis B and the virological profile we saw in the previous slide, really from hepatitis B, I think looks really a sort of inactive carrier state with low viremia, reaching maximum 1,000 units, S antigen levels actually going down from 10 to 6 to 5, 4 to 1 in the last 5 years. So this is a typical example of most of the patients relation that you describe from the natural history. So HCV is dominating and HPV is somehow either suppressed or somehow low levels of replication, and probably we would say that this is mainly related to hepatitis C, this disease. Would you agree, or do you think that's HB is playing any role here?
I think it's very reasonable. I think we always thought that the main driver was a hepatitis C infection, and that is why we tried to treat him with peg interferon. But we had our hands tied due to the bone marrow aplasia, which of course is a side effect which is related to peg interferon, and we only had peg interferon based regimens until 2014, 2015. So we were forced to wait for other treatments, but we always thought that hepatitis C was the major driver in his disease.
Yeah, I think I would say that going back to the all the data you presented about the long-term outcome, I remember your last slide showing that if you have C and B co-infection, you have 10 times more to develop cancer compared to C mono-infected. So the question now, of course, now is a little bit easier. Now we are in 2017. Many new drugs for hepatitis B are now has been available. So the question is, maybe today, if we see a case like this with ongoing viral replication for B, although not a very high level, but still ongoing, we would probably give antiviral for hepatitis B. Oral therapy is now available, new drugs are available. All this knowledge was not available 10 years ago, but maybe now we would have managed a co-infected case like this, maybe in a different way, starting at least hepatitis B treatment, waiting for new treatments for hepatitis C. And actually, this brings me to the question for you, Alessio. We are in August 2015, so new EASL recommendations, new drugs available, many new studies on Hep C. So, which was the landscape for hepatitis B treatment at the end of 2015? What we could provide or suggest for this specific case?
Yes, so we had just at the time updated the EASL guidelines in 2015, and what we said that when you wanted to consider a patient for treatment, and of course we're talking about interferon-free regimens, you have to have knowledge of his genotype. He's a genotype 1b in this case, the severity of liver disease, because some regimens are not safe in decompensated patients, but the patient has probably F2, F3 fibrosis, so he's not decompensated. And of course you have to know if he has previously failed a treatment, because this will guide your decisions in terms of ribavirin use, and if he has any conditions that impact on drug-drug interactions or safety of treatment. Luckily, the patient did not have kidney impairment, did not have liver impairment, so from a clinical standpoint, I think he's pretty simple in the choice of which treatment was optimal for him. So 2015, we had a couple of options, at least 4 options for genotype 1b. We had 3 regimens based on sofosbuvir, sofosbuvir-ledipasvir, sofosbuvir-simipavir, and sofosbuvir-daclatasvir, and a regimen based on paritaprevir, betazvir, and dazabuvir. We do not have head-to-head comparison at the time, and we still do not have them. We knew all these regimens were considered optimal, and in a patient without cirrhosis like him, 12 weeks without riba was the standard of care for a genotype 1b patient like our patient. If we had been in 2017, this would have been slightly different, because we have new regimens, sofosbuvir with patazvir and grazoprevir plus elbasvir, and also we thought as a panel in the new update that sofosbuvir-simipavir should not be recommended anymore as an optimal treatment regimen. So slight differences between 2017 now and what we had in 2015. Another difference is that currently, if you look at the guidelines, we also do suggest that some patients can receive 8 weeks of treatment, either with sofosbuvir-ledipasvir or with ombitasvir, paritaprevir, and dazabuvir. But we're very cautious that this sort of shorter treatment can be given only to patients that have mild fibrosis. We think this is not suitable for F3 patients, and also the treatment experienced patients do not fall into this category. So in our patient, he had a serious side effect, so he did not formally fail treatment. He also has a FibroScan which might hint he has F2, F3 fibrosis. So I would not go for 8 weeks of treatment. Personally, I would go for the straightforward 12 weeks treatment duration.
Okay, I think now we are going back to the case. Please, Dr. Ambrosio, could you proceed with the case. Now I guess we are starting antiviral therapy, right? Which one antiviral therapy for Hep C did you decide to start with?
So, in September 2015, the patient started treatment without ribavirin for a planned duration of 12 weeks. As you can see here, transaminases values suddenly returned to normal values, and HCV RNA became undetectable at week 8 of treatment. The patient achieved the end of treatment response. However, 4 weeks after the end of treatment, we observed a severe increase in transaminases values. Since we were able to exclude other cause of acute hepatitis and HBV DNA was high, about 7 log, we could conclude for acute reactivation of HBV. Therefore, we tested retrospectively all sera from our patient at any time point during treatment. We observed that HBV DNA levels slightly increased during treatment after DAA start.
So this is really a clear-cut demonstration that during DAA's treatment, there's been a very fast increase of HBV DNA levels, which continue to rise throughout the first 12 weeks of therapy. And this led to most likely to a very sharp increase of ALT levels, reaching a peak of approximately 500 units. So, Alessio, I mean, going back to the case now, okay, it's a little bit easy now, but we have more knowledge now than what we had 1 year ago, 2 years ago. But, it's very surprising. They're very fast. He had, 1 log, 2 logs increase just after 4 weeks. So, which could be the possible mechanism leading to a sort of hepatitis B reactivation? Is this related to the immune system? Hep C is a systemic liver disease with major immunological events, or is maybe related to the direct change of the viral interaction within the liver cell? Is there any, or maybe the combination, of course, of possible different mechanisms? Is there any clear-cut explanation right now of this so fast increase of viremia for B?
I'm not sure we have a clear-cut knowledge on why this happens, but I'm sure you remember in the interferon era, we were very, let's say, skeptical at first in treating patients with co-infection because there were some reports of patients reactivating hepatitis B once they got an SVR to interferon-based regimens, because probably this interference in terms of replication is lost, and somewhat maybe also by immune restoration following hepatitis C. I mean, the changes that happen in the liver, this leads to this reactivation of hepatitis B, which can be, of course, dangerous, especially if you're facing a patient that has cirrhosis or advanced fibrosis, like in part our patient has. So we also know that not only this was known in the interferon era, but I mean, it was completely another world, but we also know that at the time we were witnessing this case, some reports started circulating in the community of similar cases of HBV reactivation. And indeed, the FDA wrote a report and added a black box to directly acting antivirals, showing that were 29 cases worldwide of HBV reactivation in patients treated with directly acting antivirals for chronic hepatitis C. And it's a mixture of clinical pictures. Some of them were HBsAg positive, some of them were HBsAg negative, but anti-HBC antibody positive. So it's a very open, very early message that the FDA sent out, but the quality of the data at the time was really not perfect. And we have improved on this. So in the last 1 year, 1.5 years, and even at the recent ILC meeting, there's new data on the prevalence of HBV reactivation. And I think we can say that if we look at the anti-HBC positive patients, the ones that are HBsAg negative, the risk is very low, probably between 0 to 1% maximum rate of HBV reactivation and HBsAg zero reversion. On the other hand, if we look at the HBsAg positive patients, the risk is higher, between 2 and 30, 40, even 50% in some cases. But a recent meta-analysis showed that probably the correct rate is around 10, 12, 15%, and it doesn't seem to be different than what we had in the interferon area. So probably it's really just that the patients that get an SVR, they will change their viral interference and in immune status, and this will lead to a reactivation of the virus in around 10% of the patients. So as EASL, we were facing this dilemma of what to write in the 2016 guidelines, because the report was circulating and we knew that this might be an issue, and we wrote the guidelines in September when many of the data we have now were not available. So probably we took a bit of a cautious approach, and we said that all patients with chronic hepatitis B or occult HBV infection should be treated with concurrent HBV nucleotide analog therapy.
So, Alessio, going back to the last bullet point in this recommendation back in 2016, apparently, if my understanding is correct, basically almost all patients S antigen positive, independently of the liver disease severity, also all occult hepatitis B infected patients, at that time were recommended to start concurrent oral therapy. So it was a very conservative approach, right?
Yes, and I think, I can say it frankly, I think it was probably a mistake. I mean, probably we had to rush things a bit, and we probably took a bit too cautious approach. Because I personally think we should have homogenized our recommendation with the HBV guidelines, which in the end is what we're referring to. Otherwise, we provide contrasting messages to the clinicians. I think this was too wide, personally.
Okay, yes, but I think we have to remember that at that time, we were very close to the AASLD meeting 2016. There were already some rumors about some clinical cases, even cases of liver-related death, of liver transplantation, of severe acute liver failure due to hepatitis reactivation. So, okay, now we have more data, but I think it was very conservative. And given how easy and was to provide oral therapy for hepatitis B, I think overall was very well recommended at that time. So more recently, there's been a publication of the hepatitis B clinical practice guidelines. This has been recently presented at the International Liver meeting 2017. And one of the issues in these guidelines has been really, again, to go back, reassess all the new data being generated in the last 6 months compared to Hep C guidelines, and reassess the issue on how to manage hepatitis B and C co-infected patients. So there are 3 recommendations. The number 1 recommendation is for patients already fulfilling the standard criteria for hepatitis B treatment, and of course, co-infected with hepatitis C, all these should receive oral therapy for hepatitis B. A typical example would be a cirrhotic patient with HCV, HBV co-infection and detectable viremia 4B should be treated long-term with oral therapy for B. The second recommendation is for those patients not fulfilling the current recommendation for hepatitis B therapy, which means cirrhotics with undetectable DNA 4B or non-cirrhotics with low levels of HBV replication. Well, there is a strong message in the direction to oral therapy prophylaxis. According to this recommendation, prophylaxis should be considered. It should be prolonged up to week 12 after DAA discontinuation. Of course, very strict monitoring afterwards. And the third recommendation, again, is going back to the previous discussion we had on how to manage the S antigen negative, anti-core positive. Because of the new data with a risk which is less than 1% probably, we think that only monitoring ALT elevation during or after DAA treatment is probably enough then to go back and test for HBV reactivation. To summarize these possible 3 strategies, if you consider DAA therapy in someone S antigen positive or with hepatitis C co-infection, one option is universal prophylaxis, which means you start oral therapy for hepatitis B before or at the same time you start DAA therapy. The second possibility is what we call preemptive therapy or targeted prophylaxis. So you monitor DNA replication for hepatitis B during the A therapy, and if you see probably, I would say, 1 log increase, you start what is preemptive therapy for hepatitis B. And the third possibility that actually is something that we should not see anymore in our clinical units is really to not to do prophylaxis, not to do preemptive therapy, and to somehow to be very late, identify HPV reactivation after the AIDS treatment or during, and then start urgent therapy for hepatitis B. But now we go back to the case, Dr. D'Ambrosio. So how did you manage this case of hepatitis B reactivation after the discontinuation?
Okay, considering the severity of this clinical reactivation, we decided to start with treatment with tenofovir at standard dose. So the patient started tenofovir, and as you can see here, he obtained normalization of transaminases and became S antigen negative at week 16 after the end of treatment. Thereafter, he obtained a seroreversion with the development of anti-HBs antibodies.
I mean, did you stop therapy at which time point?
Yes, since the patient remained stable by serological point of view, he was, of course, cured from HCV infection. We decided to stop treatment 3 months later.
So that's another very strong point, another take-home message. Current guidelines are suggesting that if you start oral therapy for hepatitis B for any reason, either reactivation or hepatitis B related disease in a mono-infected patient, you should stop oral therapy for hepatitis B after you achieve S antigen loss with or without S antigen zero conversion. So Alessio, going back to this case, okay, we treated the case, we were very much worried. ALT were very high. But you see, DNA was already declining, hepatitis B DNA. So the question is, I mean, do we really need to start oral therapy? It was, 1 year ago, more than 1 year ago, we were very much afraid. He did not have cirrhosis. So, maybe we rushed a little bit into oral therapy for hepatitis B. Would you manage now with all the knowledge that we have accumulated in the last year or so in a different way, or would you confirm this sort of urgent oral therapy for hepatitis B?
If you remember the case, he was also quite symptomatic. He developed jaundice, you remember? So his acute hepatitis reactivation was clinically very, very relevant. He was not cirrhotic, it's true, but he had F3 fibrosis. He had a history of his familial liver cancer. So we were worried about not treating him. Although probably, I mean, he would have, I agree with you, he would have had an acute hepatitis with a flare in transaminases and probably a spontaneous HBsAg loss. But we didn't want to take the risk.
I mean, I absolutely agree with you. I think I would suggest to manage this case even today the same way. And remember, whenever you have such a huge increase of transaminase, it's only 4 weeks. With hepatitis B, it's always very difficult to know whether this will lead to or proceed to liver failure or fulminant hepatic failure, or go down and go back to a sort of inactive state. So as another take-home message, I think in this case of reactivation, whether this is related to DAs therapy or immunosuppression or chemotherapy, every time you face a case of HBV reactivation with an increase of ALT, high levels of viremia, I think you should start immediately oral therapy, because the situation could be very, very dangerous in a very short time. Now I think, Roberta, we can go back to the case. I think the case is almost finished. Are there any take-home messages that we could provide or suggest to all the people looking at this clinical case?
Okay, few data for the moment are available on the prevalence natural history of HBV/HCV co-infection. HBV status should be assessed in all patients candidate to oral treatment anti-HCV. In S antigen positive patients who undergo DAA treatment, concomitant treatment, or prophylaxis with NUCs should be considered, whilst in anticore positive patients on DAA treatment, regular assessment of transaminases should be done and could be enough according to the new published HBV recommendation. And finally, we are all aware that independently on the achievement of an SVR, patients with pretreatment advanced stages of fibrosis should remain under lifelong surveillance for HCC.
Again, the last issue or the last bullet is again very important. So, Alessio, we are recommending a lifelong surveillance for cancer in someone with SVR without cirrhosis. We agree he had probably F3 according to all the available knowledge at that time. So it would be a lifelong really surveillance, every 6 months ultrasound, maybe with or without alpha-fetoprotein. I mean, how many data are available? Because my impression is that, most of the data tend to accumulate, unfortunately, F3 and F4. So what's really the state-of-the-art situation right now on this issue?
So it's true. It's true that this recommendation that comes from the EASL HCV guidelines is clearly, once again, on the cautious side. Because we do not know exactly the real incidence of HCC in F3 patients who achieved an SVR. Most likely it's very low, probably under 0.5%. Might be higher in some patients, those with comorbidities, diabetes, the elderly. But for example, this patient would not fall into that category. So it's true, it's something that we have to study. We also have to assess the role of alpha-fetoprotein, which currently is not part of the recommended surveillance strategy, but might have a place. A patient like this, if you follow him up and you see an increase in alpha-fetoprotein values, that might mean that he is developing cancer. So these are the things we still have to, I think, identify precisely. But at the current moment, I think, as a message of caution for every one of us seeing these patients, keeping them on surveillance every 6 months with ultrasound, I think is very reasonable.
And you probably would agree with me that the risk of other complications, such as decompensation, GI bleeding or other complications, probably are probably going to be very low in this population without clear-cut cirrhosis. Although, these patients after SVR tend to start gaining weight, start to go back a little bit of alcohol. Maybe diabetes should actually decline the risk because of SVR, but probably increase the risk because of gaining weight. So I think another take-home message, I think we have to continue to follow up these F3 and F4 patients probably for many years to be sure that there will be a continuous understanding of the natural history after discontinuation, right?
I totally agree.
Okay, I think this is the last slide from this clinical case. I hope you enjoyed. I really want to thank Dr. D'Ambrosio for presenting the case, and also Dr. Alessio Gemio for helping me in the discussion. Thank you very much.